Good morning. My name is Ra Han. I'm a pediatric cardiologist here at St. Michael's Hospital, Unity Health, and I'll be presenting today on the approach to pediatric echo imaging of congenital heart disease. Learning objectives for today is to review the components of a normal pediatric echocardiogram, identify common critical cardiac defects, and to recognize red flags requiring immediate communication. So there are guidelines and standards for the performance of a pediatric echocardiogram. The most recent guidelines from JACE are in 2006. There have not been any updates since then. And the most recent SICKITS protocol was updated in 2019. So we'll be drawing from both of these when we discuss the components of a normal pediatric echocardiogram. So pediatric echocardiogram starts from the subcostal view and then works your way up. And really what you want to do is establish situs and then atrial connections, ventricular connections, and the outflow tracts. And so from the subcostal view, with the marker the patient right.
Please mute yourself when you're not speaking.
The IVC.
Thank you, Rob. Please continue.
The IVC is typically on the patient's right, and the descending aorta should be on the patient's left. And then by turning the probe 90 degrees, then you get a long axis view of the IVC and of the descending aorta. And so this is how it would look on a subcostal sweep. What you see is the IVC on the patient's right and the descending aorta on the patient's left. And then as you sweep up, you can see that the IVC connects to the right-sided atrium. Apologies, it's not looping as it should. And so you know that because the IVC enters the right-sided atrium, that the right-sided atrium is the morphologic right atrium. And so this sweep would confirm a normal atrial situs or situs solidus. With color, again, you see that it's a low velocity flow from the IVC and hepatic vein into the right atrium. You also see that the cardiac apex is pointed towards the left, and so there's levocardia. Here's the descending, here's the IVC in long axis view, and then the IVC with color and Doppler. Shifting the probe just a little bit towards the patient's left. Here's the descending aorta in long axis. And then with color. And one of the tricks to assessing the descending aorta is to move a little bit lower on the patient's abdomen rather than being right at the sternum, so that the aorta is not perpendicular to the direction of the beam. And here's the Doppler. Now, this is a view that's probably unfamiliar to many of the adult sonographers here, and it's the subcostal view. And so with the probe, with the marker at 3 o'clock, you're scanning from posteriorly to anteriorly. And posteriorly, you're going to get the views of the atria. So the right atrium on the right and the left atrium on the left. And then as you sweep anteriorly, you have the descending aorta. And then furthermore, anteriorly, you have the pulmonary or right ventricular outflow tract. And you'll also notice that the images here appear to be flipped. And we've pressed the up-down button on the echo machine. And that's because as much as possible, you want to demonstrate the images with the top being superior and the bottom being inferior. This is the right of the patient, and here's the left of the patient. So you don't have to flip it. That's something that seems very difficult in sort of wrap your head around the views, and you're not as familiar with them. But typically, when you're displaying images, you want to display the top as the superior portion of the patient or cranial portion of the patient, and bottom as the inferior or caudal portion of the patient. Heads up. So here's a subcostal sweep. And so here's the right of the patient, here's the left of the patient. Patient's head is here, and patient feet are down here. And here you can see the right atrium, left atrium, and the atrial septum. Here's a closer view of the atrial septum, no obvious defects. And then with color, and you want to do it in a slightly lower velocity, you can see there's no shunt across the atrial septum. Now, as you sweep from the posterior to anterior, you're going to get from the atrium to the left ventricular outflow tract and the right ventricular outflow tract. And so here's the atrial septum, LV and aorta, and then at the very top, RV and pulmonary artery. And then with color, again, you're looking for any shunts, and you can see a little bit of tricuspid valve regurgitation there, but otherwise laminar flow. The other subcostal view is at 90 degrees, so the subcostal short axis view, and you're going to turn the probe clockwise so that the marker is at around 5 or 6 o'clock, and you're sweeping from the patient's right to the patient's left. So from the atria and the SVC and IVC to the apex of the heart. And so here's an example. Here, this is the this is the left atrium, atrial septum, and the right atrium. You can see the SVC coming here and the IVC coming here. And again, with color, you can see that there's no shunt. There's SVC flow and there's IVC flow. And as we sweep from the right to the left of the patient, you see the aorta and the short axis sweep of the left ventricle. And again with color. Now these are views that you are probably much more familiar with, the parasternal long axis view, and these are pretty standard adults versus kids. So a standard parasternal long axis view, M-mode color through the mitral valve and aortic valve, a closer view of the mitral valve, and again with color. Here's the aorta, that's your aortic valve, and with color. And then the ascending aorta, and the aortic root. Tilting the probe a little bit towards the right, here's the tricuspid valve. And having trace tricuspid valve regurgitation would be physiologic or normal. And then tilting the probe more towards the patient's left, here is the pulmonary outflow tract. And having trace PI is also physiologic or normal. So to assess for ventricular septal defect, you want to move the probe a little bit closer to the apex of the heart, so probably a little bit lower down than your standard parasternal long axis view, and then with the color set a little bit lower, you want to sweep from the inflow to the outflow. And again, parasternal short axis views, which are pretty standard compared to the adult views. And so here we can see a trileaflet aortic valve, a normal tricuspid valve, and a normal pulmonary valve. A closer view of the aortic valve. And again with color. Here's the tricuspid valve. And with color, assessing tricuspid valve regurgitation for RVSP. And then here's the pulmonary valve with color again. And so these are standard views for the pediatric echo. Looking at the short axis of the ventricles. near the ventricular apex. And then you also want to do a sweep from the base of the heart all the way to the apex with a color Doppler set at a lower Nyquist limit to assess for a ventricular septal defect. For things like septal defects, and really for any cardiac structures, you want to get the information in as many views and from different angles as possible to confirm your findings. Now, one of the images that you don't typically get as well in adults is the assessment of the coronary artery origins. So here is the aortic valve, and here you can see the left coronary artery very clearly. And so it rises from the left coronary sinus all the way out here. And with color, you want to set the Nyquist limit as low as possible. You can see there's normal antegrade flow through that coronary artery. And here it is in 2D. And then tilting the probe or rotating the probe, it's very difficult to get both coronary arteries in the same plane. But you would also see the right coronary artery here. Very difficult to get color in the right coronary artery because it's perpendicular to the angle of the beam. But here you can see the origin of the right coronary artery clearly in a normal right coronary artery course and some speckle of flow. Moving up a little bit higher from the parasternal short axis view, you can see the branch pulmonary arteries, so pant legs, and with color, normal flow. Now moving up a little bit higher in that parasternal short axis view, what you also see is the descending aorta here. And so that opportunity allows us to assess for any PDAs. So here is the pulmonary valve, main pulmonary artery, branch pulmonary arteries here. Here's the descending aorta. Now this is a slightly younger patient, so you can see a full thymus here that helps us with the imaging. So here's the main pulmonary artery, descending aorta, and you'll see the flow from a small PDA. So descending aorta here, main pulmonary artery here. And that's high parasternal with the probe marker pointed at 12 o'clock. That high parasternal view with the marker at 3 o'clock will also give us the pulmonary veins. So here's the pulmonary veins, 1, 2, 3. The right upper is always a little more tricky to see. Apical 4-chamber view. So standard apical 4-chamber view. And again with color, assessing the mitral valve. And then here's the tricuspid valve with color, trace TR. And then here's the aortic valve. The 2-chamber view. So another view of the mitral valve. And then 3-chamber view, assessing the aortic outflow tract. And then here's another view that may not be typical for adults, the suprasternal sweep. And the reason for the suprasternal sweep is to assess the sidedness of the arch. So the aortic arch would typically arise slightly to the patient's right and then loop over the patient's left pulmonary artery. And the first branch is the right innominate artery, which bifurcates into the right common carotid and right brachiocephalic artery here, subclavian artery. And so what you're looking for as you do this suprasternal sweep is that from the aortic ascending aorta, is the first branch headed towards the patient's right, and does it bifurcate? And so if it if the first branch coming off, it heads to the patient's right and bifurcates, then you have a normal left aortic arch. So here's an example. This is the aorta here, and the first branch you can already kind of see is towards the patient's right. And as you follow it through, you can see that it bifurcates. And again, not a standard, probably much more difficult in adults because there isn't the thymus to help the ultrasound beams through. So here's the aorta, high velocity pulsatile vessel, bifurcating as it heads towards the patient's right. 90 degrees from there, now the marker is towards the patient's back. You want to assess the aortic arch. And so what you're looking for is this candy cane view. So here's the patient anteriorly, posteriorly, and ascending aorta, transverse arch, descending aorta. And then this is easier to do with a pillow or a roll under the patient's shoulders so that their head is tilted backwards. And then the right parasternal view. Now, when I first started at St. Michael's, I was actually a little surprised that this was not a standard view among the adult patients, because this is actually a view that we use in our teenage patients when we can't do a subcostal view very well. And so now the patient is rolled towards their right side, and the probe is just to the right of the patient's sternum with the marker at 12 o'clock. And so from there, you can actually see the SVC, IVC, and the right atrium, atrial and the left atrium. So the probe is just to the right of the patient's sternum. What you're seeing here is the IVC, SVC, right atrium, and the atrial septum. This is the left atrium behind. And you can see the atrial septum bows a little bit towards the right. And again, with color to assess for any atrial shunts. So those are the components of a normal pediatric echocardiogram: a subcostal view, parasternal long and short axis views, high parasternal view, apical four-chamber view, supersternal views, and a right parasternal view. So that would be a complete echocardiogram that we walk through. Now, what are critical congenital cardiac defects, and why do you, as adult sonographers, need to know about them? Let's start with some basics. What are the different critical cardiac defects? There are cyanotic defects and obstructive defects. In terms of cyanotic defects, there are the 5 T's, and you can divide them as 1, 2, 3, 4, 5. 1, you have a single great artery, so a truncus. 2, you've got 2 great arteries in parallel transposition. 3, tricuspid atresia or other single ventricles. 4, tetralogy, tetralogy of Fallot. And 5, total anomalous pulmonary venous connection. So 5 letters in TAPVC. Obstructive lesions, so pulmonary stenosis, aortic stenosis, coarctation of the aorta, and hypoplastic left heart syndrome. Going through each of these lesions briefly, truncus arteriosus is a very rare congenital cardiac abnormality where the truncus fail to divide separately into a separate aorta and pulmonary artery. So you have one great artery that has that connects both to the aorta and the branch pulmonary arteries. Over time, this causes mixing, and so the baby is desaturated. And as the pulmonary vascular resistance falls, there's increased pulmonary blood flow, so overcirculation, and then coronary steal, leading to coronary ischemia. The truncal valve is typically abnormal or dysplastic, and so you have both stenotic and regurgitant murmurs, or to and fro murmur. And so on an echocardiogram, this is a parasternal long axis view. What you would see is a ventricular septal defect and one great artery. And that one great artery overrides the ventricular septal defect and is typically abnormal in terms of the valve. So here's a greater look at that valve. So you can see the valve doesn't open completely. And with color, there's some truncal valve stenosis. Here it is in short axis. And what you see is that there's only one outflow tract. The valve is malformed or dysplastic. And then on a sweep, from the base of the heart down to the ventricles, there are no additional outflow tracts, but there are two ventricles that are equally sized. And then from this outflow tract, you can also see that was the right pulmonary artery that flashed. Second is transposition of the great arteries, where you have a normal four-chamber heart, but the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. So the great arteries are transposed or reversed. And so what happens is that the deoxygenated blood from the systemic circulation returns to the right ventricle and then goes back through the aorta back into the systemic circulation. Whereas the fully oxygenated blood flow from the pulmonary veins come into the left ventricle and then go back into the pulmonary circulation. So there's complete separation of the circulations. And then this results in profound cyanosis. On chest x-ray, it's an egg on a string because the two great arteries are one on top of the other. The mediastinum is quite narrow, so it looks like an egg on a string. And on echo, on a parasternal long axis view, you would see that the pulmonary artery and the aorta are parallel to each other. So in this image, you can actually see it better in this color Doppler image, where you would see the two arteries in long axis, both of them in the same plane, which you would normally would not. If you swept up, you would also see that the second, the more posterior great artery would bifurcate into the branch pulmonary arteries. In subcostal views, you can here's the aorta, here's the pulmonary artery, but really what you want to, what you are looking for are the great arteries crossing as you sweep, or are they in the same plane? So here, the two great arteries are parallel. Moving on to the third lesion, tricuspid atresia or single ventricles. What you're really looking for is there a normal four-chamber heart? Are there two atria and two ventricles that are more or less normal in size? And so this is an example of a single ventricle. The patient has an unbalanced AVSD where the valve is predominantly over the left ventricle, and there's a very small or hypoplastic right ventricle. And then again, with color, you can see the inflow from both the right atrium and left atrium predominantly enter the left ventricle. Tetralogy of Fallot, one of my favorite cardiac lesions, so I may come back at a different time to talk about tetralogy of Fallot. But here, there's a malalignment in the ventricular septum where the outlet ventricular septum is deviated anteriorly, resulting in pulmonary stenosis, the aorta that overrides the ventricular septum, a large VSD, and right ventricular hypertrophy. Because the main pulmonary artery is small, the mediastinum is relatively small, and because of the right ventricular hypertrophy, the cardiac apex is pushed upwards, resulting in a boot-shaped heart. Parasternal long axis view, what you'll appreciate is the ventricular septum, ventricular septal defect, and an overriding aorta. The aorta has some commitment towards the right ventricle. And here, because there's not a lot of pulmonary stenosis, the ventricular septal defect is actually shunting from left to right. Short axis, you appreciate the anatomy even more because here's the outlet ventricular septum, and you can see that it's deviated anteriorly, causing crowding underneath the pulmonary valve, resulting in subpulmonary stenosis. that also results in a large VSD that really would never close on its own because of the malalignment of the ventricular septum. Our patient here has good sized branch pulmonary arteries, which likely accounts for the fact that they're shunting left to right. But there is some degree of pulmonary stenosis, so they would always have a murmur. And finally, total anomalous pulmonary venous drainage or connection. The pulmonary veins arise from the lungs, and instead of joining the back of the left atrium, it has found a different route back into the heart. So in a supracardiac TPVD, it typically connects up through a vertical vein into the innominate vein or the SVC. So there's complete mixing in the venous circulation. And so there's an obligate right to left shunt. If there was not a right to left shunt across the atrial septum, there would be no systemic cardiac output. A supracardiac TPVD would give you a snowman's heart because of this confluence of vessels in the mediastinum would result in a second sort of cardiac shadow. And so on an echocardiogram, what you would see on a parasternal long axis view is a dilated and hypertensive right ventricle. Here in the parasternal short axis view, here's the left atrium, and what you see is that there's a line here in the left atrium that separates the body of the left atrium from the pulmonary venous return. And you can also see it here in the apical four-chamber view. Here's the pulmonary venous confluence, here's the body of the left atrium, and the two are separated. And by color, you can see there's color flow here, the two are not connected. And then this parasternal short axis view, high parasternal short axis view, you can see that there are pulmonary veins, but as you follow it up, it joins up with this large vertical vein into the SVC. Large vertical vein into the SVC. Going back to the subcostal view, here's the atrial septum, and there's a foramen ovale that's open towards the left, towards the right, sorry, left. And on color, you can see that the atrial shunt is from the right atrium towards the left atrium. So there's a right to left shunt across the atrial septum. Going to obstructive lesions, critical pulmonary stenosis also has an obligate right to left shunt across the atrial septum, as the pulmonary stenosis and high right ventricular pressures is keeping the foramen ovale open. And here's the stenotic pulmonary valve. And then finally, coarctation of the aorta presents quite differently in neonates compared to older children and adults. In neonates, it's a duct-dependent lesion. And so for as long as the ductus is open, what you're looking for is a right to left shunt across the ductus. And so then this leads to a duct-dependent perfusion so that once the ductus closes, there's shock or there's lower limb cyanosis. Whereas in older children and adults, you develop some collateral circulation, and the main presenting finding is hypertension, and they would have left ventricular hypertrophy on ECG and echocardiogram. So here's a neonate with a coarctation of the aorta, and it's really the right ventricle that appears to be enlarged and hypertensive. Again, in short axis view, the right ventricle is large and hypertensive. And then here's the ductal cut. So here's the high parasternal view. This is the main pulmonary artery. And then back here is the descending aorta. And with color, what you would see that there's flow acceleration in the descending aorta and a ductus that actually shunts from the pulmonary artery to the descending aorta. So right to left. Going up to the suprasternal view, you can see that the transverse arch is quite thin. It's the same size as the carotid artery. And then there's a narrowing right here at the aortic isthmus. Now, the other half of my clinical life is fetal diagnosis and counseling. And so the vast majority of critical cardiac lesions are actually diagnosed antenatally, and that helps us plan for care. And so this is an example of a hypoplastic left heart syndrome. You can see that in the four-chambered view, you see a large right ventricle, a large right atrium, but a relatively small left atrium, and really a very small non-apex forming left ventricle. It's hypoplastic left heart syndrome. Here's an example of tetralogy of below, a normal four-chamber heart, but as you sweep up, you see one large aorta that overrides the ventricular septum. So in 2017, we started using pulse oximetry to detect critical cardiac lesions in babies prior to discharge home. So at 24 hours of life, all newborn babies have oxygen oximetry screening to assess for congenital heart disease. So what does that mean? So if your saturations are less than 95% in the hand and in the foot, then they will repeat in an hour, try again in another hour, and then eventually we'll call for a pediatric consultation or cardiac consultation, or may need further investigations such as an echocardiogram to assess for critical cardiac lesions. Practically speaking, there are 145,000 births in Ontario each year. About 40 babies who are not antenatal diagnosed or diagnosed on newborn exam will be discharged home with a critical cardiac lesion. By using pulse oximetry with a sensitivity of 76%, additional 30 would be detected, but 10 would still be missed. With a specificity of 99.5 to 99.9%, even though it's quite a high specificity because the incidence of undetected congenital cardiac lesions are low, you have over 700 false positives. And so what that means is lots of babies are born who may fail pulse oximetry, but don't actually have congenital cardiac disease. So 1 in 25 will test positive, but will only 1 in 5 will have critical cardiac lesions. So that's a lot of babies that are potentially needing additional investigations. And so if they're looking well, they may ask the home institution to do a further assessment with echocardiogram rather than transferring them to a tertiary care center such as here or Sick Kids. And so that being the case, if you're working in an adult hospital that has labor and delivery, then you may be asked to do a quick echocardiogram so the baby doesn't necessarily have to be transferred, particularly in this pandemic era. So it's important to review some of the important guidelines. And so this is the guideline for adult sonographers performing echocardiogram for critical cardiac lesions. And they go through some very important red flags. My only, I think, critique is that there are just way too many of them. And so it's hard to sort of keep track. Absolutely, if it doesn't look normal, someone else needs to take a look at it. But I think we can simplify this a little bit more. So here's the simplified version. Question 1, is there a normal four-chamber heart? Where is the heart? Is it on the left or is it somewhere else? What are the size of the major chambers? What is the gross assessment of the ventricular function? And what are the AV valves, the mitral valve and tricuspid valve look like? Are there two outflow tracts and are they crossing over each other? Or are they in parallel, or is there only one? And does the aorta resemble a candy cane when you do imaging from the supersternal view? Or is it hard to image at all, or does it look like something else? What is the direction of flow across the atrial septum? What is the direction of flow across the PDA, if there is a PDA? And this is very important these are very important markers of cardiac function, but also important clues that there may be other issues that we may not be able to identify on a screening assessment. And ultimately, if it can't make it look normal, it probably isn't normal. And so you don't need to have the specific diagnosis or a complete assessment of the critical cardiac lesion, but what is your concern? What is the part that doesn't look normal? And that helps us know how to prioritize. So review the components of a normal pediatric echocardiogram and how some of the views may be more unique to pediatrics than in adults. We reviewed some common critical cardiac lesions and some of the important echo findings that would point to those diagnoses. And then the red flags requiring urgent communication. And here we see a subcostal view with a right to left flow across the atrial septum. So regardless of what's causing that abnormal flow, that in of itself should prompt transfer to a tertiary care center for an urgent assessment. Any questions?
So once again, I want to thank you on all of our behalf of Dr. Han, who presented to us today. It's always very instructional and always, it's one of those skills that we as adult echocardiographer and adult sonographers in general, we don't encounter these too often. So when we do, then we really need help to save the bell. It is one of those things that we're very glad to have you as an expert close to us, but then again, there are also many colleagues who work in other settings that may not have access to you directly. So again, wants to thank you for your very, very comprehensive review of the segmental approach to echo, especially in the very young. And also, we do run into these patients still, of course, because patients who had congenital heart disease when they were young had benefits from the innovative surgery. Some of them were created at in Canada, and such as the mustard procedure, for example, and so on and so forth. And many of these patients are surviving into their adulthood. So we now get to see them. And not all of them end up in the congenital heart clinic because they are all over. So once again, thank you. Any questions? So this round